So in this video, I want to introduce you to a couple of agonists that you are gonna encounter in physiological tracings and how their classic response is gonna look like. And again, we're gonna go the same order as I've discussed in another video. We're gonna first look at diastolic pressure, then pulse pressure, we're gonna predict mean arterial pressure, and then I'm gonna look at heart rate. We're gonna distinguish between direct and indirect effects, and then I'm gonna come up with a net effect on heart rate. So the first agonist that we're gonna discuss is phenylephrine, which is an alpha-1 agonist. So if we want to first look at diastolic pressure, a major determinant is systemic vascular resistance. So we're going to look at our vasculature. There are alpha receptors. They mediate contraction. Therefore, if you stimulate them with an alpha-1 agonist, your diastolic pressure should go up. Now, in terms of pulse pressure, we said the major determinant as we're using for this drug tracings is inotropic state, and more specifically, does the drug affect beta 1? And this drug does not affect beta 1, so there should be not any change. Mean arterial pressure is diastolic pressure plus 1/3 pulse pressure. And if you just use this, well, the mean arterial pressure should go up because diastolic pressure changed also went up. Now, in terms of the heart rate, first let's look, is there any direct effect? So an alpha-1 agonist does not directly affect the SA node because the only adrenergic receptor that sits on the SA node is a beta-1 receptor, not alpha-1. Now, indirectly, yes, we're going to have an effect because the mean arterial pressure increased. So what's going to happen when the mean arterial pressure is going to increase? Well, the baroreceptors in the aortic arch and the carotid sinus are going to pick this up, and there's going to be a lot of stretch. So there's going to be a lot of nerve traffic via cranial nerve 9 and 10 to the NTS. And the NTS will do its magic. It's going to say, if the blood pressure was high, withdraw sympathetic and fire parasympathetic. Therefore, we're going to get a lot of parasympathetic outflow here towards the SA node, and our heart rate is going to decrease. Now, the net effect of heart rate should be a decrease because there was no direct effect, only the baroreceptor reflex. The next agonist that we're going to look at is a classical response to a low dose of physiological dose of epinephrine. So in physiological doses, epinephrine is particularly a beta 2 agonist. It loves it more than alpha-1, has higher affinity on beta 2 than alpha-1, but also stimulates beta 1 receptors. So therefore, on the vasculature, we're going to see mainly smooth muscle relaxation because the beta 2 receptor is more affected than the alpha-1. So therefore, our diastolic pressure should go down. Pulse pressure should go up because we're going to have beta 1 receptors on the ventricular myocyte that are going to be stimulated with epinephrine. Now, this is always a difficult scenario because now we have kind of two opposing effects. And there's no way you can really predict it, but you have to know the classical response to this physiological dose of epinephrine is a slight increase in blood pressure, and therefore we're also going to call epinephrine sometimes a pressor because it's slightly going to increase mean arterial pressure. Now, in terms of direct effects on heart rate, should go up because we have beta 1 receptors on the SA nodes, but we're also going to get a baroreceptor reflex. Now, the baroreceptor is always going to be as much as the blood pressure change was. So the magnitude is determined by the blood pressure change. So as the blood pressure doesn't change a lot, we're also not going to get a very significant baroreceptor reflex, only a little bit, a decrease in heart rate. Classically, epinephrine injected in this physiological doses gives you a increase in heart rate. Probably this baroreceptor is just not enough to overcome here the direct effect. The next agonist that I want to look at is norepinephrine. Norepinephrine stimulates alpha-1 receptors and beta-1 receptors. It does not have any affinity for beta 2. Now, in terms of systemic vascular resistance, we should conclude that we get smooth muscle contraction, so diastolic pressure is going to go up. Pulse pressure is going to go up because we have a beta 1 effect. Mean arterial pressure is going to go up because both diastolic pressure and pulse pressure went up. Now, direct effect on heart definitively up because here SA node, beta 1 receptors. And then now we're going to get a baroreceptor reflex, and because there's a high blood pressure, there's going to be a lot of nerve stretch, a lot of nerve traffic to the NTS, and the NTS is going to say withdraw sympathetic and fire parasympathetic. So therefore we're going to get a decrease in heart rate. Now we're going to see that there is an opposing effect of the heart rate. And the rule of thumb is usually when you have opposing effects and there was a significant change in blood pressure, the baroreceptor is going to win. So therefore, in a classical response to norepinephrine, you're going to see a drop in heart rate. So we're going to write here baroreceptor wins. And again, the only exception is epinephrine, where the baroreceptor is not going to win in the classical response. But again, the blood pressure change was also not a lot. Isoproterenol is a non-selective beta agonist, so it stimulates beta 1 and beta 2 receptors. And therefore, if you look at systemic vascular resistance, it's going to go down because we're going to have smooth muscle relaxation. There is an effect on ventricular myocytes, increase in inotropic state, increase in pulse pressure. Again, here we go opposing directions. So with the exception of epinephrine, which is special by its own, if you just look at diastolic pressure plus 1/3 of pulse pressure, so maybe the diastolic pressure has a little bit more weight in, and in fact for isoproterenol we see a mean arterial pressure decrease. For heart rate, we're going to definitively get a direct effect in increase because beta 1 on the SA node. Now because we got a decrease in blood pressure, we're going to fire sympathetic and withdraw parasympathetic. So there's going to be an increase in heart rate. And now that's going to be nice because they go both in the same direction, so nothing to worry about. We're going to get an increase in heart rate. Acetylcholine injected at low dose, what does that do? Acetylcholine is a muscarinic agonist, so it's going to stimulate M2 and M3. And we're going to use low dose because when you inject high dose, you also need to think about peripheral ganglia effect, and it gets pretty complicated. So we're going to only do low dose, going to have a muscarinic agonist. So if you look here at systemic vascular resistance, I mean, we have it written down, inject acetylcholine. So if we inject it, well, we're definitely going to stimulate M3 receptors on the endothelial cells and on the smooth muscle. And they have opposing effects, but we need to know the winner is NO-mediated relaxation. Therefore, our diastolic pressure is going to go down. Now, what's going to happen to pulse pressure? No effect, because no effect on beta 1 receptors. Mean arterial pressure should go down. And now, in terms of the heart rate, we're going to have a direct effect. We're going to stimulate this M2 receptors, GI coupled, so this is going to lead to bradycardia. But because the mean arterial pressure was dropping, we're going to get increase in heart rate because of the baroreceptor reflex. And the net effect is going to be again increase. The baroreceptor reflex wins. Again, the baroreceptor reflex is always based on the magnitude of blood pressure change, but usually it wins. So this concludes the video on different agonists that you're seeing frequently in physiological tracings.